being recorded. Why?
The test was very quick.
No. Oh, no. Well, my camera won't switch.
This reason probably is a good opportunity. If you don't have symptoms, you don't need to test. Current testing format, although regular
No surgery on the plane, and that is very low.
There's all new technologies, I would say.
Yep.
All the we're looking at officials. Contact Field will give you all the latest information, new testing that is available, including steps we're making for Americans will be able to test themselves until the government suspense.
Using puffin, so
kind of invasive.
I keep on doing that.
Walter Reed Hospital processed the test. They had a lab.
We're buying some random for.
Welcome to Surgery Squad's virtual laparoscopic RNY gastric bypass surgery. Dr. Jeff, and I'll be your guide for this procedure.
Yeah.
You ready?
You better.
Gastric bypass surgery is designed to assist a patient in weight control. This operation will create a stomach pouch from the existing stomach. We'll then attach a reduced section of the stomach to the small intestine. There are several common types of gastric bypass surgeries. We've recommended laparoscopic RNY gastric bypass surgery for a patient. The procedure will usually take 2 hours to perform, but with skills like mine and magic of the internet, I bet we can whip this stomach into shape in about 5 minutes. Our patient is prepared for the procedure with mild sedative, and now the anesthesiologist places a mask over her nose and mouth, and she'll drift off into dreamland. From here, we'll place an endotracheal tube down the patient's throat. You're up. See if you can get the tube in place. Work. The tube's connected to a respirator. The patient is ready to go. Now we can begin our laparoscopic procedure. The first thing we'll do is make 6 incisions in the abdomen. Slide the scalpel in where I have marked to make the incisions. Be careful. These are small incisions. Don't get in your way.
The bruise instantly the second knock goes in.
Technique. You must have an excellent teacher. Oh wait, that's me. Next, we'll place a device called a trocar into each incision.
As I've said, decidedly,
These devices allow us to easily slide the instruments into the abdomen. Some of the instruments we'll use include light and a camera, so we can see what we're doing on video monitor, as well as the surgical instruments, such as the stapler. Now, to give us plenty of room to work, we fill the abdomen with carbon dioxide. Let's face it, with a newbie we'll need all the room we can get. Time to start the gastric bypass. We'll use frequency at work. In RNY gastric bypass, we made up to 90% of the stomach by making the patient's stomach the size of an egg. We'll do this by first placing a line of staples that separate the smaller new stomach from the whole old one. Then we sew along the staple line to make sure there are no leaks. As the patient heals, scar tissue will form to create a permanent separation. Click the stapler where indicated to create the new stomach pouch. We'll now separate the small end from the old stomach, about 2 feet. The low part of the intestine will be connected to the new, smaller stomach with a 1/2-inch opening between the stomach and the intestine. It's kind of like rerouting traffic on the 405. Use
Jeff, shut up. Who we watching? I'm back.
the electrocautery device to create a 1/2-inch opening where indicated in the new stomach pouch.
Go bye-bye.
Now, drag the loose end of the intestine to the new stomach pouch to attach it. I'll have sutures hold in place. Because we need secretions from the old stomach to assist in digestion, it gets reattached to the small intestine several feet below the new stomach. This part takes some guts. I need you to drag the free end of intestine attached to the old stomach over to the small intestine where it.
I feel so bad for no.
She's supposed to be throwing the flower down and no.
What happened? Did the sock crash? So I bet it's crashed. Because I gotta go back full screen.
Again, I'll fall into place. New small stomach pouch created. Everything has been reattached, and we checked for any leaks in the sutures. This new configuration allows our patient to feel full sooner when eating, but also lets the fluids from their original stomach aid the digestive process. I'll need you to remove each of the laparoscopic instruments and probes.
Flower petals down.
I don't know. I just got the store. Too slow.
Now we need to suture each of the incisions.
Whoop, 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 whoop. There. I'm sorry. You shouldn't have let me job. I should colonoscopy next. I have no idea what will be recommended next. So.
Nice work. I bet that won't leave a scar. Now the patient goes off to recovery. In most cases, they'll spend a few days here in the hospital so we can monitor their progress. Afterward, our patient will meet with her doctor and a nutritional specialist. They will assist her with her lifestyle and eating habits. You've been a great help. Why not try another fantastic surgery at surgerysquad.com.
Hey, what's this? Please no. do colonoscopy though. Look, what are you doing? Hello? Wait, Robin. Don't scroll down. My mouse is dirty though. I know how to clean it. Let's take off this part. Stop listening. I'm gonna need that.
Hello, and welcome to Surgery School Virtual Colonoscopy. I'm Dr. Jeff, and I will be guiding you through this colon today. Also known as the large intestine, the colon is responsible for the final stages of the digestion. It absorbs remaining water and electrolytes from indigestible food, accepts and stores food remains that weren't digested in the small intestine, and eliminates solid waste from the body. A colonoscopy allows your doctor to view inside your entire colon using a device called an endoscope. As the scope moves into your colon, your doctor views the output on the monitor to check for growths or polyps.
What was that?
There are several parts to the colon: the cecum ascending, the transverse, the descending, and the sigmoid. A colonoscopy can check each one of these areas. The one thing about having a colonoscopy is that a doctor can find polyps and remove them immediately. This is the most effective way to prevent the development of colorectal cancer. However, you'll need to cleanse your colon 24 hours before the test by taking laxatives or performing a fleet enema. Also, use of the endoscope might accidentally tear the colon walls and cause bleeding. Plus, you'll need to be sedated during the exam, which should take about 30 minutes or longer if any polyps are found. We have a 53-year-old female waiting for her colonoscopy. Let's get scrubbed and take care of this. Our patient is lying on her left side, knees drawn up to her stomach. She's wearing a gown, and we have a sheet draped over her. Let's set her up with an IV drip of the sedative.
How does that?
Great. Now we'll wait a few minutes for the sedative to take effect. Our patient is sedated and ready. She stated that she's cleansed her colon, and I've already used a lubricated gloved finger to check for blockage. Be sure to tell the patient that she should breathe slowly through her mouth to relax her stomach muscles if she feels cramping. We'll insert the endoscope into the anus and slowly move it into the colon. The endoscope contains a small camera and light and a pair of forceps so we can remove any polyps we find. First, let's lubricate the scope for easy insertion and passage through the colon. Carefully insert the scope into the patient's anus. Slowly move it into the colon.
Breathe! Please breathe.
We can watch the camera's output on monitor. We're into the rectum now. Nothing so far. Let's move on into the sigmoid colon. Slow and steady. You're doing a great job. Descending colon's next. Now's a good time to remind our patient to breathe slowly through her mouth as we do the exam.
Make sure to breathe. It's that too.
All right, let's move into the transverse colon.
What happened is that? What's on that?
Uh-oh, looks like we've got a small polyp in the transverse colon. We'll use the forceps to remove it. Fine work. We need to remove the scope so we can bring the polyp out. First, let's use some heat to cauterize the spot and try to stop that bleeding.
They rotate the whole thing? There. He's hurt.
Fantastic. Let's slowly withdraw our scope and get that polyp out.
Get out of my camera.
Let's go back in to check the rest of her colon. The name of the colon where we found the polyp? That's right, the transverse colon.
I thought that was bad. Where'd you get one of them? What? Kinder eggs? Found it somewhere. You need to clean that. I can see all the dirt.
Back in the transverse colon now. Everything's looking fine, and you're doing a great job. Now's also a good time to remind our patient to breathe through her mouth slowly.
Remember to
Moving now into the ascending colon. And there's another one. Let's take it out the same way we did the other.
So this Kinder egg at you. So to breathe.
Oh, look at here.
Oh.
To order a lockdown in Tennessee.
Probably should go get that. Someone said so. I'm not talking yet.
Back in the ascending colon now, and we move into the cecum. And all looks good. Let's take out the scope and get our patient into a recovery room. The patient is now in recovery. She'll probably be there 1 to 2 hours. She might feel bloated or need to pass gas. And since we removed 2 polyps, she'll probably have a small amount of blood in her stool. We'll also do a biopsy of polyps. She should call her doctor immediately if she has heavy rectal bleeding, lower abdominal pain, develops a fever, feels dizzy, vomits, or experiences swelling in her abdomen. Well, good news. The biopsy showed our patient's polyps were benign. Since she's in her 50s and there were polyps found, she should have a colonoscopy every year. You did a great job today. While you're here, try your hand at one of our other surgery school.
I want to see what it's like to get your adenoids removed. Is that out?
He ain't doing it though.
What?
Putting the state on lockdown. If they would, it'd help a lot.
Blood right all over the thing. It's got blood all below it.
I don't know. If they're doing surgery, people have blood in them.
Oh, I know. It has blinker fluid. Is that popping? Is that popping? This I know neck.
Hello, and welcome to Surgery Squad's virtual adenoidectomy. I'm Dr. Susie, and I'll be guiding you through this procedure today.
I'm Susie.
Our adenoids are located at the back of the throat, just below where the nose connects, also known as the pharyngeal tonsil. They are part of our immune system because they protect us from the bacteria or viruses that might enter the body when we breathe or swallow. They are more important for children than adults, and they shrink as we get older. In some adults, they become inflamed, which can lead to infections, sleep apnea, better known as snoring, and ear infections, since enlarged adenoids might block the eustachian tubes, which drain fluid from the ears into the throat. Normally, these symptoms can be treated with antibiotics, but when these infections occur more frequently, we perform an adenoidectomy to remove them. Having an adenoidectomy, if it is required, can reduce the number of ear infections, reduce recurring chances of sinusitis, and can alleviate sleep apnea. However, there's a risk of developing an infection at the removal site. Plus, the procedure might not alleviate all the problems associated with adenoids. For instance, if ear infections continue, the problem might be elsewhere. Our patient today experienced sleep apnea and ear infections. Let's scrub in and get to work. We'll need to use a general anesthetic for our patient. Why don't you help out? Can you find a suitable vein in the patient's ear?
Y'all didn't hear me hiccup.
Looks good to me.
No.
Sterilize the injection area using a sterile alcohol.
Hiccup was so bad that what caused it.
You have a dirty hand.
Insert the needle and advance the angiocatheter into the vein. Small bursts of blood in the angiocatheter hub is what medical professionals refer to as a flashback. This lets us know that the angiocatheter is correctly positioned in the patient's vein. While placing a small amount of pressure over the vein to collapse it, remove the needle. This will reduce the amount of blood that may discharge out of the angiocatheter when the needle is removed.
What are you doing?
It feels like a gummy worm.
Really?
Mm-hmm. So like, feel the vein.
Now that the needle has been removed, I'll dispose of it in a sharps container. We need to secure the IV with tape and test the line. Great! Now we'll wait a few minutes for the anesthetic to take effect. One more thing. Since we'll be working in the patient's nose and mouth area, we'll need to make sure he can breathe. Let's insert a breathing tube into one nostril. Great job! Our patient is under and breathing. Now we're ready to remove the adenoids. We'll begin by putting an endoscope through our patient's nose so that we can view our work on a monitor. When we reach the back of the nose at the entrance to the throat, we'll be able to see the adenoids. Okay, good. Now we can see the adenoids. We need to open the mouth and get the tongue out of the way so we can begin our procedure. To do that, we'll use a special retractor that opens the mouth, depresses the tongue, and locks into position. Great work! We're going to remove the adenoids using a device that uses suction cautery. The device uses electrical pulses to liquefy the adenoid, then suctions the liquefied adenoid out. This method is faster and results.
It literally becomes liquid with this tool. Watch. That's nasty. That's how it works. Literally becomes liquid. Watch. What? I'm going now. No, don't erase the spam. It looks like spam now. That Pepsi was good. I don't know why they threw it away.
The adenoids are gone. Now all we have to do is remove all of our equipment and get our patient to recover.
I'm gonna come back. I'm gonna use this water ball actually. Okay. Oh, sleep peacefully, buddy.
Our patient's in recovery. He'll be able to go home in a few hours once he can breathe easily, cough, and swallow. We'll provide some antibiotics, and once he gets home, he needs to drink plenty of water to keep hydrated.
I'm gonna go
He'll also need to stay away from some foods, but he'll get to eat ice cream, sherbet, popsicles, and jello for a couple of days. He might experience a burned taste in his mouth, which will subside after a couple of days. He should brush his teeth often to help alleviate that taste. Scabs might form in the back of his throat from the surgery, and of course, he should contact his doctor if there's bleeding or excessive pain from where the adenoids were removed.
Call 1 2 3 4.
did a great job today.
Obviously not real.
Try your hand at one of our other surgeries here at surgerysquad.com.
That's all? Well, that sucks. It sucks. Hello, I want to go. Please don't tell me that's in the ball. It is. I'm gonna rise up like Phoenix.
Hello, and welcome to Surgery Squad's Surgery.
I love
I'm Dr. Susie, and I'll be guiding you through the procedure today.
Well,
Cataract lens inside the eye. The lens is located behind the pupil and focuses light on the retina.
recording.
A cataract causes loss of vision that can't be corrected with glasses, contact lenses, or even LASIK, so it must be surgically removed. We're going to remove the clouded lens and replace it with a new one called an intraocular lens, or IOL. The surgery takes about an hour, and it can be done on an outpatient basis. Today, our patient is a 66-year-old woman who has noticed an increased blurriness in her vision, as well as decreased night vision. She saw her eye professional, and she detected cataracts and recommended her to us for surgery. Let's begin. First, we need to administer a relaxing sedative intravenously. This will make our patient drowsy, but not put her to sleep.
You have a dirty hand too. This is the best part.
Just prior to surgery, additional drops of anesthetic are applied.
Karen, she's all ready. So, bye bye. I can't think of her nose to give her drops.
We'll use a device called a speculum to hold the eye open wide during the procedure.
Stop with the eyeball.
Place the speculum for me, please.
I can do the same. Okay, I won't.
We do a small painless needle cyber incision. This is called a limbocorneal incision. It's done by making a small cut in the limbus with a knife.
Tablet. Never got the first recording in. But it sure did
Next,
get the
we use
first
a knife to make a corneal tunnel into the interior chamber of the eye.
Split from about the center of the screen all the way to the right. Not a great.
A thick, transparent viscoelastic is injected to fill the space between the cataract and the delicate underside of the clear cornea in front of it.
I can play with Papa in
This is done to keep the cornea from collapsing during the procedure. Help me out and inject the fluid into our patient's eye.
Neither shots. Oh, God.
Now we make a 2.85 millimeter wide incision at the cornea for the cataract removal. This is done with an extremely thin diamond scalpel.
Oh, that's sharp. Oh, that's sharp.
A bent needle is inserted into the incision, and used to poke a hole into the clear sac that holds the lens with the cataract.
This is where Trolls World Tour is coming out. So that's why I started singing that. Are you sure it's safe?
Needle is dragged to cut the line. The incision made will insert the forceps to grab the torn sac and tear a circle out of it. Now you will need to inject fluid into the incision to separate the lens from the capsule. This causes the lens capsule to float, so that it can rotate during the next step. We'll now perform phacoemulsification, or phaco. This is done by using ultrasound to break up the affected lens so it can be removed from the eye. To do this, we pulse and drag the device to cut across the cataracted lens. We repeat phaco from the other direction to create 4 pieces. The phaco is then used to substance of the old lens. I'll need to remove the last remaining soft cataract material out of the eye, leaving behind the clear, empty lens capsule.
Ew. How are you supposed to get that one?
When you're done, inject viscoelastic fluid into the lens capsule to keep it collapsing.
Obviously, don't try this at home.
The flexible intraocular lens is rolled up for insertion by the assistant and placed in a soft tube. The IOL is now injected through a tube into the vacant lens capsule.
Oh,
a probe is used to spin lens into place.
You can actually...
The thick fluid we added to the eye will need to be removed, and any remaining microscopic cataract fragments should be rinsed out as well. The incisions in the eye are generally self-sealing. Very rarely that we need to add a suture to close the incision. In our patient's case, we don't need any sutures. The lens is now in place. Our patient will need to drive her home after cataract surgery, and she shouldn't drive until she's cleared at her follow-up appointment tomorrow. We'll prescribe medicated eye drops to use several times each day for a few weeks after the cataract surgery. And she'll need to wear a protective eye shield while sleeping or napping for about a week after surgery. A special pair of post-op sunglasses will also need to be worn to protect her eye from sunlight and other bright light as her eye recovers.
That would have been better.
You did a great job today, surgeon. While you're here, try your hand at one of our other surgeries here at surgerysquad.com.
Definitely not happen, Susie. How to cook an eyeball? How to cook a turkey? I'm gonna get back up. I'm gonna rise up. Oh God!
I'm walking on America's funniest beams, but I have no legs, so I can't fall down.
Breast implants? No.
I guess I would just have to sit here and watch it LOL.
Fun fact: make you get breast cancer. Comment if you want to see any of these. What's a C-section? No, I'm doing it though. Circular. One of what? I think I'm 1.5. So I'm 5-minute crafts. I keep on forgetting.
You did this? I thought.
Come on if you want to see me bash someone's nose in. I think I'll just do bash. I'll just bash someone's nose in. I don't think I drank his Pepsi before I started recording. That's how. Wait, do we all have our adenoids removed?
No. They took my tonsils, so that's my adenoid.
No, I'm talking about 3 of us.
No, adenoid.
We do?
All 3 of you.
Welcome to Surgery Squad's virtual closed rhinoplasty surgery. I'm Dr. Susie. Today we will be performing rhinoplasty. It's what's commonly referred to as a job. In this cosmetic surgery, our patient is a young lady who's looking to change the shape of her nose. We'll perform a closed rhinoplasty procedure to reshape her nose into something she finds more appealing. Some surgeons will perform this surgery using a local anesthetic and sedation, which makes the patient numb and in a dreamlike state. I prefer to work with a patient under general anesthesia and completely asleep. What we're doing today is reshaping the bridge of the nose. Our patient feels it's too wide and doesn't like the hump on it. The thinning of the nose is called an infracture. I'll bet you can't guess what the widening of the nose is called.
Fracture.
Alright, I'll tell you. It's an outfracture. Some patients may also want the tip of the nose reshaped. That's called typoplasty.
Yes.
But as I was saying, this patient only wants an infracture and some reaping. Easily done. To begin the procedure, we need to open the nostrils as wide as possible. We do this with a retractor. Can you place the retractor patient's right nostril?
Okay, Doctor.
No nostril opened wide. We'll make an incision inside in a crescent moon shape. That will allow us to access the bones and cartilage that make up the nose structure. I've made the incision. Can you use the forceps to remove that portion of nostril? Surgeons must be hyper-vigilant when doing this portion of the procedure, as it can damage breathing and sense of smell. To reshape the nose, we're going to chip off the dorsal hump with a chisel tool called the osteotome. We place the osteotome at the base of the hump and then carefully tap on it with a small rubber mallet. This has to be done very gently and takes a touch. I'll position the osteotome and you tap the end with the hammer.
That was not gentle. Look how hard I did.
Now that the hump is loosened, we need to pull the bone and cartilage out of the nose. Use the tweezer-like forceps to slip it out of the incision.
Pick your nose, friend.
Now that the bump is out of there, we need to smooth the edges on both sides with a rasp. The space left by the bone we've removed is referred to as an open roof. To close the open roof, carefully tap the osteotome on the path that I've marked. This breaks the nasal bones so we can reposition them. Tap the osteotome once each time I reposition it on the left and right nostrils.
Not tap, you mean whack. Oh, that was actually a tap. That was not. Yeah.
Now that the bones are broken, I just take my fingers and reposition them to close the open roof. Because we made such perfect breaks, the bones slip right into place and the nose is perfect. A few stitches to close up the incisions, and then we place nasal airway splints in each nostril to hold things in place. Strips go across the nose, and an external nasal splint is added to hold everything tight. Our patient will have some bruising and minor pain for a few days. We'll remove the splints in about a week. Most of the swelling will be gone then, but there can be a bit left for a few months. And there we have it. Thanks for coming by. Catch more of my great surgeries here at SurgerySquad.com.
Bobby Danza. LASIK is that surgery with the laser, isn't it? For your eyes. LASIK.
Yeah, that's that surgery where you're not supposed to have to wear glasses again, but it don't last but so many years. Amy had that done years ago. She was having her glasses. Oh, she don't never put them on.
I'm about to do it. I am about to do it. Too late. Don't click it. Step 1, wrap it. Step 2, let it thaw out. Step 3, stick it in the oven. Step 4, eat it. Done.
I'm not one.
I'm cooking. This is on surgery. Don't ask.
Hello, and welcome to Surgery Squad's Thanksgiving special, How to Cook a Turkey. I'm Dr. Jeff, and I will be guiding you through this delicious procedure today. Nothing helps me relax more after a challenging day in the OR cooking a fine meal. And I especially love doing it for family and friends at a big Thanksgiving dinner. The guest of honor at any Thanksgiving dinner is the turkey. Today, we're going to show you how to prepare, cook, and carve a bird to help make this Thanksgiving and others to come delicious and memorable. Just like we do for a surgery, we have to make sure we have all the tools necessary for the procedure. Here's what I use. A roasting pan with handles and rack for catching things as the bird makes. Aluminum foil, butter softened at room temperature, kosher salt, fresh ground black pepper, and meat thermometer. Before you eat the bird, you must make sure it is completely thawed in your refrigerator. Never leave a turkey up to thaw at room temperature, because that might bacteria to form. Our patient, subject today, is a 24-pound turkey who is nicely thawed and ready to be the big star.
Why did
Can
he
you
call
pat
him
the
a
turkey
patient?
dry with
He's
some paper
obviously-
towels as I remove the gizzards and neck
Oh,
from the
my
body
God,
cavity?
subject. Subject, so people. Pat. And he's here.
Let's wash up and get cooking. No matter what size bird you're working with, it's important to remember to keep moist. If the bird is too dry, your guests might have to lie and tell you how delicious the turkey is, when they really wish eating a TV dinner. Here's how I prepare a turkey to keep it moist. First, rub a softened stick of butter deeply into the turkey skin, which will make it nice and brown as it bakes.
I'll take it. Good enough.
Good. Next, sprinkle a generous amount of salt and pepper all over the bird for seasoning. Great! The bird's all seasoned up, but not quite ready for the oven. Some folks traditionally fill the cavity with their stuffing mixture. I don't, mainly because it introduces some problems. First, bacteria can find its way into the bird. Also, if you cook your bird to the perfect temperature, the stuffing will be too dry. It's best to bake the stuffing as a separate dish. In stuffing, let's put it in some aromatics, rosemary, a stick or two of cinnamon, a lemon, a handful of peeled cloves. As the turkey cooks, these guys, they'll release all kinds of flavors that will get right into the meat. This guy's going to taste good. One thing before we put it in the oven. Take a large piece of aluminum foil and form a tent over the bird. It will keep any moisture from evaporating. We'll get off during the last 45 minutes of cooking so the bird can brown up. Ready for the oven? Okay, we've got our preheat at 325 degrees. Generally, we'll cook a turkey at about 15 minutes per pound. Our turkey is 4 pounds. So multiply 15 by 24 to get 360. Then divide that by 60 to get 6 hours. All right, let's put the game on the TV and get ready to greet our guests. There's about 45 minutes left. Time to remove our foil tent at temperature. Smelling great. There's some nice drippings in the pan for gravy. Everything seems okay, but let's see where we are with the bird's temperature. Most turkeys come with this little pop-up device that's supposed to tell you when your bird's done. Thing is, it's not always accurate. That's where you need the meat thermometer. It's going to give you the most accurate temperature. We're looking for a temperature of 161 degrees for the white meat and about 180 degrees for the dark. So it's not quite ready yet. Let's leave the foil off so the turkey can get a nice layer of browning on it. I've got to get back to my guests. Here he is, all nice and brown and ready for carving. First, cut here in this thin layer of skin that holds the thigh to the breast. Cut all the way down to your carving surface and stop when you reach the joint. Now just take your hand, washed of course, and press down on the thigh. Remove it when you hear the socket pop. Then just cut it off. Put that on a separate plate to carve up later. Now let's begin carving the rest. Nice and clean. Ought to have you over to carve our turkey too. Let's cut a few more slices. These guests are getting hungry.
No way turkey's that thick.
Wow, those are some delicious looking slices. Great job.
I didn't even
Let's just go ahead and eat. See you at dinner. Our turkey is well gone, but everyone else is recovering nicely. They'll want to rest thoroughly to let their food digest. Guys might need to loosen their belts a few notches for comfort. Your guests may also stray into the kitchen for leftovers. That's normal and encouraged. It means less you have to clean up. You did a good job today. Thanks for your help in the kitchen. Have a wonderful Thanksgiving, and we'll see you back in the OR working on one of our other surgeries here at SurgerySquad.com.
That's mine.
That's what Brandon's playing with yesterday.
I said stop it.
Please. You need yesterday.